There's a window most people don't know they're in. It closes slowly, and by the time you notice it's gone, the conversation you're having with a surgeon has already started. That window is your fascia's elasticity, the natural give in the tissue holding your cheek fat where it sits. It starts narrowing gradually in your 30s. By your 40s, it's noticeably tighter. And once it's tight enough, no amount of at-home work reverses what surgery would need to correct. This isn't a scare tactic, it's a timeline. And it's why the 90 seconds I'm about to walk you through matter more the longer you wait to try them. If you've looked into buccal fat removal, you already know the pitch. Your cheeks look fuller than you want them to. A surgeon explains that everyone has a pad of fat sitting inside the cheek, between the muscles you chew with, and that removing part of it will carve the sculpted, contoured look you're after. The logic is clean. Fullness equals fat. Remove fat, remove fullness. Thousands of people find that logic convincing enough to book the consultation, put down a deposit, and go under a blade for a face they haven't actually diagnosed correctly. I want to take that logic seriously before I take it apart. It deserves that. The buccal fat pad is real. It's a genuine anatomical structure sitting deep in your cheek, and yes, its size varies from person to person. Removing part of it does change the contour. Surgeons aren't wrong about the anatomy existing. Where the logic breaks isn't in the existence of the fat pad, it's in the assumption sitting quietly underneath the whole decision, that fullness is a measurement of volume. Here's the first assumption worth putting under a light. Volume is only half the story of how full a cheek looks. The other half is position. Picture two people with the exact same amount of fat in that pocket of the cheek. One of them has it sitting where it's meant to sit, tucked back, supported, following the natural curve of the cheekbone down toward the jaw. The other has that same fat pushed slightly forward and down, bulging just enough to catch the light differently, casting a shadow under the cheekbone instead of along it. Same volume, completely different face. A surgeon looking at the second person sees fullness and reaches for a scalpel. What they're actually looking at is position, not mass. This is where I want to borrow something from how investigators work, because the comparison is useful and then it stops being useful. Pay attention to where it stops. A detective looking at a scene doesn't ask, "What's here?" They ask, "Why is this here and where should it actually be?" Evidence out of place tells you more than evidence that's simply present. But a detective's job ends at identifying the misplaced object. Your face isn't a crime scene with a fixed answer waiting to be found. It's closer to a suspension system on a vehicle. Something built to hold weight in a specific position, using tension across multiple points, in something that sags or shifts, not because parts are missing, but because the tension holding them has changed. That's the difference worth sitting with. A detective finds where something ended up. A suspension system explains why it moved there in the first place, and, more usefully, how you get it to move back. So the second assumption, if fat position, not fat volume, is doing the work in that fuller appearance, then the assumption that surgery is the only lever available starts to wobble. Surgery removes mass. It cannot move mass back into position because it isn't designed to address whatever pushed the mass out of position to begin with. If the actual driver is something pulling the fat pad forward, removing part of the pad doesn't fix the pull. It just gives the pull less material to work with. Some people who go through buccal fat removal are satisfied. Others come out the other side months later, describing a face that looks different, but somehow not like what they pictured. Hollow in a way that reads older rather than sharper, because the same forward pulling tension is now acting on a smaller amount of tissue with less cushioning to soften the effect. Everything I've just walked you through, the position, the pull, the difference between what surgery can and can't touch, connects to one system, and there's a complete way to work with it. The Connected Face protocol lays out 12 fascial releases, sequenced across 30 days, with labeled diagrams that show exactly where to place your hands for each one, plus a daily tracking sheet so you can see your own progress instead of guessing at it. It's in the description and the pinned comment if you want the full sequence, rather than just the one release we're covering today. Now, the release I'm covering today only makes sense once you understand what's actually pulling. So let's slow all the way down and look at the mechanism directly. No comparisons, no stories, just the anatomy as it actually behaves. The buccal fat pad sits in a defined pocket between two muscles you use constantly. The muscle that runs along the side of your jaw when you clench your teeth, and the muscle that fans out from your cheekbone toward the corner of your mouth. That pocket isn't a loose bag. It's a fascial compartment, meaning it's wrapped and partially suspended by connective tissue, sheets and cords of collagen that anchor the fat pad to nearby structures, including a ligament that runs from your cheekbone down toward your jaw, and another band of tissue connecting the fat pad's covering to the deep chewing muscle beneath it. This suspension is what keeps the fat pad sitting up and back under normal conditions, tucked against the curve of your cheekbone rather than drooping forward. The chewing muscle at the side of your jaw, the one that bulges when you bite down hard, sits directly beneath and behind this suspension system. When that muscle is relaxed, it's soft, pliable, and it doesn't pull on anything around it. When that muscle is chronically tight, which happens from clenching during sleep, from stress-driven jaw tension held all day without you noticing, or from years of one-sided chewing habits, the muscle shortens and thickens along its length. A shortened, thickened muscle beneath a fascial suspension system doesn't just sit there quietly. It changes the tension on everything attached above it. The connective tissue anchoring the fat pad gets pulled downward and slightly forward, dragging the fat pad along with it, out of its tucked position and into a more forward, more prominent one. This is measurable in a rough way you can check yourself. Chronic jaw tension from clenching has been associated in dental research with measurable increases in masseter muscle thickness. In some studied populations, a difference of several millimeters between habitual clenchers and non-clenchers, enough to be picked up on ultrasound. A muscle that's thickened and shortened by even a small margin changes the angle and tension of everything layered on top of it. The fat pad hasn't grown. The scaffolding around it has shifted, pulled by a muscle working overtime, 24 hours a day, without your permission and mostly without your awareness. This also explains something that surgery-focused thinking struggles with: why the same face can look fuller in the morning and less full by evening, or fuller during a stressful week and less full during a relaxed one. Fat doesn't fluctuate that fast. Muscle tension does. If what you're seeing in the mirror on a bad week is tension-driven positioning rather than fixed volume, then removing tissue permanently to solve a temporary tension problem is solving the wrong variable, permanently, with a scalpel. There's one more piece worth naming honestly, because I don't want to overstate what this is. Age plays a role too, separate from tension. The ligaments suspending the fat pad lose some elasticity over time, the same way ligaments throughout your body do. That part of the picture isn't fully reversible through soft tissue work. It's a genuine structural change, and I'd be misleading you to claim otherwise. What tension work addresses is the muscular pull layered on top of that structural aging. For most people, that pull is doing more of the visible work than the aging itself, especially before the mid-50s. That's not a claim I'm making lightly, and it's also not one I'm walking back. It's simply the honest boundary of what a release like this can and can't do. I want to tell you about someone who went through the consultation process before ever trying anything like this. Not a name, not a case file, just a pattern I've seen often enough to describe accurately. A woman in her early 40s sat across from a surgeon, listened to the buccal fat removal pitch, and asked one question that stopped the conversation cold. Will this come back? The surgeon told her no. Removed fat doesn't regenerate. What he didn't tell her, because it wasn't really his to explain, was that the pulling forward she was seeing wasn't really about the fat's mass at all. She left the consultation, sat in her car, and pressed her fingers along the side of her jaw where it meets her cheek. It was sore. Not painful, just tight. The way a fist stays tight after being clenched too long. She'd been grinding her teeth for 2 years, since a stressful job change, and had never connected the tightness in her jaw to the fullness she saw in the mirror. She didn't book the surgery. She started working the tension instead, and over several weeks watched the same fat pad she'd been ready to have removed settle back into a position that made the whole lower half of her face look different, without a single gram of tissue missing. So here's the 90-second release, and here's how to know whether it applies to you before you spend any time on it, because not everyone's fullness comes from this source, and pretending otherwise would waste your time. Sit somewhere quiet and place 2 fingers just in front of your ear, at the point where your jawbone hinges. Clench your back teeth together, gently, and feel for a muscle bulging under your fingers. That's the muscle we're talking about. Now relax your jaw completely and notice whether that spot stays tender even at rest, whether it feels thick or ropey compared to the skin around it, and whether pressing into it produces a small ache that travels slightly toward your cheek. If you feel that traveling ache, the tension is likely reaching the fascia suspending your fat pad, and this release is worth your time. If the area feels soft and unremarkable at rest, your fullness may have more to do with structure than tension, and no amount of release work will change what genetics or aging built. Assuming the ache is there, here's the release itself, and I want you to picture doing this rather than counting steps, because the feel of it matters more than the sequence. You bring your fingers back to that same spot at the hinge of your jaw. You press in, not hard, just enough that you feel resistance from the muscle rather than skin sliding over bone. You hold that pressure steady while you slowly open and close your mouth several times. Small movements, letting the muscle work against your fingers instead of freely. You'll feel the tissue underneath start to give, the way a knot in a shoulder eventually softens under sustained pressure. After about 30 seconds there, you move your fingers slightly forward toward the meaty part of your cheek just above your jawline, and repeat the same steady pressure, this time with your jaw held gently open rather than moving. You're following the muscle's length, not staying in one spot. The last 30 seconds go to slow circular pressure along that same line, moving from the hinge point toward the front of the cheek, following the direction the tension has been pulling, working against it rather than with it. 90 seconds total, once in the morning before that muscle starts its all-day work, and once in the evening after it's had all day to tighten again. What you're not doing is anything that requires memorizing a numbered list or downloading a chart to follow along. It's one continuous motion along one line of tissue twice a day. And the only thing worth tracking is whether that traveling ache from your diagnostic check softens over 2 to 3 weeks of consistent work. If it does, you'll likely notice the fat pad settling before you consciously register why your face looks different. That's usually how it goes. If it doesn't shift after several weeks of daily work, that's useful information too. It tells you the structural aging piece is playing a larger role than the tension piece. And that's a conversation worth having with a professional who can look at your specific anatomy, not something that forces through more pressure or more frequency. What surgery removes, it removes permanently, whether or not tension was ever the actual cause. What tension creates, tension can also release. And that's the entire distinction worth understanding before you make an irreversible decision based on a reversible problem. The point of walking through all of this isn't to tell you surgery is always wrong. Some people genuinely do have excess volume that no amount of tension release will change. And for them, a surgical conversation is the right conversation. The point is that the decision deserves to start from an accurate diagnosis, not from an assumption that fullness always means fat. Press your fingers to your jaw before you press a pen to a consent form. Give the muscle 2 or 3 weeks to prove or disprove itself. The fat pad you were ready to have removed might simply be waiting for the tension pulling it forward to let go. Here's the challenge, and it's a fair one. Do the diagnostic check today, right now if you can. 2 fingers, that spot at the hinge of your jaw. Clench and release. Feel for the ache. If it's there, commit to the 90-second release, morning and evening, for 14 days. Not longer, not shorter. 14 days is enough time for fascia to respond if it's going to respond at all. At the end of those 14 days, look at your own face, not a mirror you're second guessing, just a straightforward look, and ask whether the fullness sits differently than it did on day 1. If it does, you found your answer, and it cost you nothing but 3.5 minutes a day. If it doesn't, you've ruled out one variable cleanly, and that's worth something too. It means whatever conversation you have next, with whoever you have it with, starts from a place of actually knowing your own face instead of guessing at it. Whatever you decide after those 14 days, decide it holding a fact instead of an assumption. That's the whole ask. If you found this useful, subscribing means the next mechanism I dig into like this one finds you when it's ready. And if you know someone who's been quietly researching buccal fat removal, send them the diagnostic check before they send anyone a deposit. That's a better first appointment than the one they've already scheduled. 90 seconds, twice a day, 2 fingers on your jaw. The excerpt you pasted already ends on a complete, resolved close. 90 seconds, twice a day, 2 fingers on your jaw. Adding approximately 960 more words after that would mean reopening a script that's already landed its ending that reads as tacked on, not a continuation. 2 ways to actually hit 3,400 words cleanly. 1, the close you pasted isn't final. There's more script after it I haven't seen, and the real gap is earlier. For example, more examples/cases before the challenge section. If so, send me the missing middle section. 2, this truly is the end, and you want the extra approximately 960 words woven in before the challenge/close. For example, another case study, a deeper mechanism explainer, or an objection and rebuttal beat, with the existing close moved to follow it. Which is it? Is there more script after this, or should I insert additional content before this ending and keep this as the final close? Let me give you one more piece before you go, because I want you walking into those 14 days with your eyes open about what you might find and what you might not. I've heard from people who did this exact check and felt nothing. No ache at the hinge, no tension pulling forward, just normal muscle, normal jaw, normal face. And their instinct every time is to think they did it wrong. They go back and press harder, dig deeper, convinced the sensation is hiding somewhere they haven't found yet. It isn't hiding. Absence of the ache is data too. If your masseter isn't holding chronic tension, then buccal fat removal was never going to be undone by a release technique because there was nothing structural pulling that fullness where it sits. In that case, the fat pad is just the fat pad, genetics, or age, or simply how your face was built. And if you want it gone, removing it is the direct answer, not a workaround you talked yourself out of. The diagnostic isn't designed to talk you out of the surgery. It's designed to make sure you're not paying for a solution to a problem you don't actually have. And then there's the other outcome, the one that's harder to sit with. You do the check, you feel the ache, unmistakable, right where I described it. You commit to the 14 days, you do the release morning and evening, you're diligent about it. And at the end, your face looks the same. Not worse, not better, just the same fullness, sitting exactly where it sat on day 1. This happens too, and here's why. Tension in the masseter can be a symptom of something that isn't going to resolve in 2 weeks of self-massage. A bite misalignment that's been loading that muscle for a decade. A grinding habit that resets the tension every night while you sleep. A jaw joint that's been compensating for years. 14 days of release won't undo structural patterns that took that long to build. What it does is tell you the mechanism is real, even if the 2-week dose wasn't enough to fully clear it. That's not a failure of the check. That's the check doing exactly its job, pointing you toward a dentist or a physical therapist who works with the jaw, instead of a surgeon. Because the actual work that needs to happen is in the muscle and the bite, not in removing tissue that was never the problem to begin with. So there are 3 doors at the end of those 14 days, not 2. The fullness shifts and you found your answer cheaply. Nothing was there to begin with, and the surgery you were already considering is probably still the right call. Or something was there, it's stubborn, and you've just identified a longer-term intervention that has nothing to do with the scalpel. All 3 of those are better than where you started, which was a consultation room and a number on a quote, with no way to know which of these 3 situations you were actually standing in. That's really what this whole conversation has been about, if I'm honest. Not fascia specifically, not the masseter specifically. It's about the fact that so much of what gets pitched to us as a structural problem, something wrong with the tissue, something that needs to be cut away, is actually a tension problem wearing tissue's clothes. Your face didn't get this way by accident, and it's not going to be fixed by accident either. It responds to what you do to it every day, whether that's clenching through a stressful year or spending 3.5 minutes finding out what happens when you stop. I keep coming back to the image because it's the whole method in miniature. 2 fingers on your jaw. Not a mirror, not a consultation, not a deposit. Just 2 fingers, finding out what your own face has been trying to tell you the entire time. 90 seconds, twice a day, 2 fingers on your jaw.